Um, أنا هتكلم عن البوست تروماتيك knee arthritis, how to manage bone defects and work. زي ما سمعنا من الدكتور طارق في آخر سلايد, to achieve a perfect total knee, you have to have a proper lower limb mechanical alignment, and you have to have a good positioning of the components and the proper fixation of the metal to the bone and appropriate soft tissue balance. So what's the challenge of the bone defect? The bone defect is going to compromise the bone implant interface, and this means a malalignment of the components with potential revision. Why we end up with bone defects? Advanced osteoarthritis. So like in this case with severe varus, just you have got the classic post-medial defect, rheumatoid arthritis, secondary to trauma, and the defects coming from trauma usually severe and complex. It could be due to previous osteotomy, osteonecrosis, infections, neoplastic conditions, and so on. If there is anything peculiar about the post-traumatic knee arthritis, this is by far the third most common cause of total knee arthroplasty after primary osteoarthritis and rheumatoid arthritis. It tends to happen in younger patients. It's about 10 years, on average 10 years younger, and it progresses more quickly. You end up with a more complex defects. The potential complications are relatively high because sometimes you need to remove metalwork, sometimes you deal with previous scars, with stiffness, with soft tissues, with extra-articular deformities, and you have to exclude latent infection, so it is sort of revision surgery scenario. How can you classify the bone defects? It could be contained or uncontained, it could be central or peripheral, or according to its size. And we can see here, in the varus knee, this is the classic peripheral posteromedial defect, and in the valgus knee, this is the classic lateral central defect. This is by far the most commonly used classification for the bone defects, Anderson Orthopedic Research Institute, AORI, where the T stands for the tibia and F for the femur. And we have three types, type 1, 2, and 3. Type 1, it's minor defect without compromising the stability of the implant. Type 2, you have got metaphyseal bone loss. It's significant that it requires reconstruction. If it's only in one condyle, it's 2A. If in both condyles, it's 2B. Type 3, you have got a significant metaphyseal bone loss that compromises the attachment of soft tissues, the collaterals, and the patellar tendon. This is important. As we see from the picture of ORI classification, the classification after you have done the bone cut. So you establish your classification after the cut. Why? Because if you have something like this, you don't go low like this and you say, I have no defect. No, you have a limit. Your limit is 10 millimeters from the lateral tibia or 2 millimeters from the medial tibia. After your cut, you can classify your defect. This will take us to the zonal fixation, principle of zonal fixation in total knee with bone defects. We have got three zones. Zone 1 is the epiphysis. Zone 2, this is the flare of the bone metaphysis. Zone 3, it is the shaft or the diaphysis. Again, in red, the joint surface. In green, the metaphysis. And in blue, the diaphysis. To obtain a solid primary fixation of implants into your host bone, you have to have a solid fixation in at least 2 of these 3 zones. And you have to bear in mind that the key is the metaphyseal fixation. Management options, tibia reduction osteotomy, and you can fill the defects by bone cement or bone grafting or different sorts and kinds of metal augments. And in this special situation, with massive soft tissue and bone loss, you can use tumor prosthesis. Tibia reduction osteotomy. What you do, you translate the component away from the bone defect. You don't do more horizontal cut. Your osteotomy is vertical, and this is sort of soft tissue release, and this is a very safe and effective procedure. Cement augmentation, bone cement only. You can fill the defects up to 5 millimeters, and it's a great dimension after you have done your cut. If the defects from 5 to 10 millimeters, you can augment your cement with screws, and this is very safe and effective, especially in elderly, low-demand patients. Bone grafts, a lot of techniques here. In these two pictures, you can convert an oblique peripheral defect into a rectangular space. You can take the advantage of the stepped pattern to have more stability. And for the big defects, you can go to the impaction grafting and wire mesh. So more sliced bone grafts from 5 to 7 millimeters and wire mesh. And you have to use a stem to offload your bone graft. Metal augments, it's wedges, blocks, and as far as the biomechanics is concerned, the blocks are superior to wedges, and it's solid titanium, aluminum, vanadium alloy plus blasted surface, and you can replace up to 20 millimeters of segmental bone loss, and you have to use a stem. So for the substantial cavitary cancellous bone loss at the metaphysis, and still you have got a surrounding intact cortical bone, you can use cones or sleeves. These are porous or trabecular metal. It serves two functions. Mechanical function, it gives you stability for the bone defect and for the implant. And it has got as well osteoconductive function. It acts as a modular scaffold for osseointegration, and it serves when incorporated into the graft or the cement. We use this for only large defects, like in post-traumatic defects, our talk today, and rheumatoid arthritis, plus stents. No. So a little bit more information about the difference between the cones and the sleeves. The cones, the whole thing is 3D pore structure made of tantalum or titanium, and add to its so in addition to its mechanical and osteoconductive properties, there is decent evidence it has got as well osteoinductive properties. So it acts sort of, like cancellous bone. While the sleeve, it's different. The sleeve is a solid component of titanium that fits into the implant. Only the external layer is porous. And this gives you better initial stabilization of the defect and of the prosthesis. The choice of the constraint in treatment of bone defects is pretty much dependent on the soft tissue, on the ligaments, and not the bone defect itself. So if you cannot balance your collaterals properly, you can use a CCK or RHK knee. This statement might be controversial. The use of RHK in primary knee, this could be an excellent long-term survival rates. This could be controversial, but it's generally accepted that we can use RHK in this indication as a primary knee in cases with massive bone loss that sacrifices attachment of the soft tissue, ARI3, or severe osteoarthritis plus neuromuscular disease like poliomyelitis. And this is related to the yoke design on the tibial component that allows the tibial platform to rotate. It's a rotating hinge, and thus offloading the shearing forces, and it gives it a long survival. Sorry. So to sum up, it's pretty simple. If the bone defect is small, less than 6 millimeters, go for cement alone. If it's between 6 to 10 millimeters, augment your cement with screws. If a big bone defect from 10 to 25 millimeters, if he's a young active patient, you can use a structural bone graft. If he's old, low demand patient, metal block with a stem. For the big defects, bone defects beyond 1 inch, impaction bone grafting and metal mesh, or if you have access to metaphyseal cones plus CCK. Massive defects with no soft tissue attachment, ORI type 3 bone defects, go for sleeves and rotating hinge knee. That's it. Thank you very much.